Recording in progress.
Hello, everybody. Want to welcome you to Pediatric Grand Rounds and looking forward to a great 2026. As we start off the new year, it's my pleasure to introduce our Grand Round speaker today, Dr. Amy Gelfand, who's a professor of neurology and pediatrics here at UCSF, and she directs the Child and Adolescent Headache Program here. Dr. Gelfand serves as the editor-in-chief of Headache, which is the journal of the American Headache Society, and she specializes in the epidemiology of pediatric migraine and the diagnosis of childhood periodic syndromes, such as abdominal migraine and cyclic vomiting. And today she's going to share with us her work related to the evolving landscape of migraine therapies in children. And I'm delighted to welcome Dr. Gelfand today. Thank you.
Thank you so much for having me today. And I'm thrilled that migraine is the topic kicking off 2026. That's fantastic. These are my disclosures. I don't think any of them are relevant to today's talk, other than as the editor of Headache, I may oversight that journal perhaps. These are the objectives for today's talk. I'm hoping it will be very practical, that at the end you will have some concrete skills that you can take into your clinics and your practice wherever you are, and also some insight into what the cutting edge is in pediatric migraine management in 2026. So, starting at the beginning, when we meet a patient who's coming in for recurrent headaches, our first goal is to make a specific headache diagnosis. And that first division point is whether we're talking about a primary headache disorder, meaning something like migraine or tension type headache, where there's not a secondary process that's driving it, versus a secondary headache disorder, which of course we want to rule out, like idiopathic intracranial hypertension or space occupying lesion. And what I'm showing here are the International Classification for Headache Disorders, third edition. That's the current edition of ICHD. This is what we use in pediatric headache to classify different headache disorders. These are the diagnostic criteria for migraine. I've highlighted in red the areas where they vary from those in adults. Attacks might be shorter in children. They can be as short as 2 hours untreated or unsuccessfully treated, whereas in adults, that would be 4 hours. Headache is more often bilateral than unilateral in kids with migraine. That's true really through their late teens, early 20s. So a bilateral headache should not dissuade you from making a diagnosis of migraine. And especially for younger children, they don't have to be able to articulate their sensitivity symptoms like photophobia and phonophobia. We can infer those from behavior. If they're pulling the sheets up over their head or asking for the television to be turned down, we can infer things like photophobia and phonophobia. Versus tension type headache, which really is, I think, more of a diverse clinical presentation, but can last anywhere from 30 minutes to 7 days. There's no difference in the diagnostic criteria between kids and adults. And there's really an absence of sensitivity features. So they're not having things like movement sensitivity, light sensitivity, smell sensitivity. It's more of a musculoskeletal etiology. And when making a diagnosis, it's all about the history. That's what I love about headache, is that 90% of the time we can make the diagnosis right in the room, talking to the patient and their family. We don't need ancillary testing. And that's something that I really enjoy about headache. And one of the great things you have is got a parent in the room, and they can give you first person history about their own headache history and family history. They can tell you about the history when the patient was young and recall if they were a colicky baby or they had abdominal migraine or any of those sort of things. But that is also the most challenging thing about a pediatric headache, is that you've always got a parent in the room. And out of abounding love, the parents often want to give the history, but it's the child's head, it's their body, and they're the ones who know best about what's going on. So there's three simple steps that I follow in taking a headache history. First is it's like elementary school. We assign seats. We put the patient closest to the clinician. That's a nonverbal signal that this is going to be predominantly a conversation between the clinician and the patient, and the parent is there for loving support. And then this takes about 60 seconds. And sometimes I get lazy or rushed in clinic and I skip it. And I always regret it when I do this because invariably, if I don't do this, the history comes out of the parent and it's all jumbled. So this is worth taking the time. And you don't have to use my way, but having your own way of setting expectations, I think, is really helpful for taking a headache history. So I say, I'm going to ask you a number of questions about the headaches you're having. I'm going to ask most of these questions to you, young Paddington, because it's your head, it's your body, you know best. But I don't want that to be stressful. If there's anything you can't remember about which doctor said what, when, about which medicine, you can phone a friend to your parent at any time. And then you can just go from there. And it lets everybody in the room know that I'm interested. I've got a plan. And this is going to be predominantly a conversation between the clinician and the kid. My mentor, Peter Goadsby, has this phrase that good headache histories are taken, not given. And the longer I am a headache doctor, the more I think this is true. If the history is given, it's like drinking from a fire hose. It's just all coming out. It's in whatever order it is. It's at whatever speed it is. But if you're taking the history, it's actually quite a pleasure. It's very easy to have everything fall into place and figure out what you're dealing with. And then you just take the history. Kids are actually, I think, excellent historians, despite the fact that sometimes they're called not, but I think they're really quite good at it. And it can be most helpful to ask about with your worst headaches, because when headache is more severe, that's when the features come out. That's when the photophobia comes out. That's when the light and sound sensitivity and smell sensitivity comes out. And the features don't have to be severe to count. Mild photophobia, that's photophobia. The only thing I think is a little bit tricky for kids under, say, 9 or 10, fourth or fifth grade is features of time. They might not be able to tell you exactly how many hours or frequency of days per week or days per month. The other thing that I think can be helpful is inviting them to draw a little picture if they're younger of the features of their headache. This is a nice one that shows you the pounding quality with the hammer there and the photophobia with the sunglasses in the sun. The crinkle paper on the exam table is fabulous for this purpose. So that's a good use to do that. Just hand them a pen. And when you go through this systematically, it is really clear whether you're dealing with something like migraine, which is much more than a headache disorder. It's really, I think, best thought of as a disorder of amplified and distorted perception of stimuli, whether they're external stimuli or internal stimuli, versus tension type headache, which is a musculoskeletal problem and doesn't have any distortion of stimuli. Migraine is very common in children. This is showing age on the x-axis and prevalence on the y-axis divided out by sex. And our age group is highlighted in the light cream. Before puberty, girls and boys are equally likely to be impacted by migraine. As you go through puberty, you start to see more girls than boys affected until you arrive in adulthood, where there's a 3-to-1 ratio. Chronic migraine, which is having at least 15 days of headache per month for at least the last 3 months, is also very common in children. 0.6% of elementary school age kids have chronic migraine. To give you a reference point, 0.5 to 1% of kids have epilepsy. So the worst form of migraine is just as common as all forms of epilepsy in children, and it's even higher in adolescents. Kids who come from a socioeconomically disadvantaged background are 4-fold more likely to have chronic migraine than those who come from a more advantaged background. And kids with migraine are more likely to miss school and perform poorly in school than kids without migraines. It's a treatable cause of poor school performance. So I wanted to bring it now to a more granular case level and say, let's imagine an adolescent girl. This is epidemiologically the most common type of patient that you will have with migraine. She's coming into the clinic with Throbbing headaches once or twice a month for the last 6 months. They're bifrontal, bitemporal, moderate to severe in intensity. They last between 4 and 24 hours and are associated with photophobia and phonophobia, no aura. Vitals are shown here. She's got a normal neurologic exam and general examination, including, importantly, fundoscopic exam. So what would you make for her diagnosis? She's had at least 5 attacks. This requirement is true whether you're 4 years old or 44 years old. You have to have had at least 5 lifetime attacks. And she's been having them once or twice a month for the last 6 months. So that's definitely met. The attacks are lasting for the needed duration of time. So 4 to 24 hours for her, but could be even shorter potentially. She's got bilateral headache, which is fine for her age group. It's got a throbbing quality, which is the same as pulsating, moderate or severe intensity. She's checking more than 2 out of 4 of these. And she's got photophobia and phonophobia. This E sounds like a throwaway. This is not better accounted for by a better diagnosis, but it's really not. It implies that you have taken a thorough headache history. You've done a thorough neurologic exam, including a fundoscopic exam, and everything looks good. So this patient has migraine. And if you want to get more specific, it's going to be migraine without aura. And there are treatment guidelines. The most recent set are from 2019. These are joint guidelines from the American Academy of Neurology and the American Headache Society. There's guidelines for acute treatment. There's guidelines for preventive treatment. And on the acute side, which we'll take first line things are the common things that you would think of: acetaminophen, ibuprofen. These have been shown in randomized placebo-controlled trials down to age 4 to be superior for acute treatment of migraine in children. And so the guidelines reflect that. And they say first line treatment is ibuprofen 10 mg per kg. Great. But she's already tried that. And most of the time, if a patient is bothering to have made an appointment and come and talk to you about headache, they've already tried those sort of things. So she's already tried that. It's at an appropriate dose for her weight, which is 61 kilos. And it doesn't really help her, or it just helps a little. And same deal with the acetaminophen. And she's really looking for something else. So what are we going to offer for this patient? Triptans. This is migraine specific therapy, migraine specific acute therapy. There are 4 triptans that are FDA approved for those under 18, with rizatriptan going down to age 6. There's 7 triptans total, and you could use the other 3. This is just which ones are FDA approved. And the guidelines certainly would support the use of triptans for people who don't respond to things like ibuprofen. And I want you to feel comfortable writing that prescription. So what should you pause about? The 2 things to think about, and these are rare, honestly, are in our patient population: history of stroke, peripheral vascular disease, or myocardial infarction. That sometimes happens in a neurology clinic. They might have a history of stroke, but it's very rare. And uncontrolled hypertension, which might happen in a nephrology patient population. And the reason that that's a labeled contraindication is that triptans do have an arterial vasoconstrictive effect. So if you have vasculopathy, if you have uncontrolled hypertension, those could be concerns. The other things that you'll find on the label, for at least the most common one, sumatriptan, is a history of Wolff-Parkinson-White syndrome. That's really more of a historic accident, where anything that happens during a registration trial. So if one person has WPW during the registration trial, it ends up on the label. And these are not arrhythmogenic agents, so you don't need to worry about that. But if no one mentions it to you, it might cause you alarm. So I wanted to make sure to mention it. And then the other thing that's going to be listed there is what's called either hemiplegic migraine, which is when you have weakness on one side of the body. That is a rare form of aura. And I would imagine if that's happening, you're probably going to refer that patient to neurology, or what used to be called basilar migraine, which is now called migraine with brainstem aura, where people will get diplopia, dysarthria, vertigo, loss of consciousness. Again, a very rare form of aura that would probably be a patient who would go to neurology clinic. These ones are here really out of historical accidents. I mentioned with the Wolff-Parkinson-White that was in the registration trial, actually for zolmitriptan, but got a bit generalized. And then we used to think that hemiplegic migraine and basilar migraine were more arterial types of migraine, but they're really not. So this is just a historic accident that people with this form of aura were excluded from the safety trials. If you want to get the best possible bang for your buck from a triptan, you want to combine it with an NSAID for the best possible outcomes. In adults, data show that if you combine sumatriptan, and sumatriptan is most commonly used first-line triptan, that's usually going to be tier 1 on any insurance plan. If you combine sumatriptan with naproxen and NSAID, the patient is more likely to be headache-free by the 2-hour mark and less likely to have the headache come back within the following 24 hours than if they took either of those monotherapies alone. So unless there's a contraindication to an NSAID or a triptan, ideally, they're taking these two things together. And that also comes out in our guidelines. If they are not fully responsive to a triptan, combining it with an NSAID. So the most common prescription that I'm writing in clinic is for an adolescent who's about 60 kilos, and I'm writing sumatriptan 50 milligram tablets with naproxen 500 milligram taken together. And I want you to feel comfortable writing that prescription by the end of this talk. So we'll go into a little bit more detail. There are some situations where that's really not going to work. Let's say they're having so much vomiting with their attacks that they can't hold down an oral medication. There are alternatives. Sumatriptan can be given as a sub-Q injection. It can be given as a nasal spray. Zolmitriptan can be given as a nasal spray. They don't have to be able to absorb the medication orally. Also, if they're young, if they're under age 8 or 9, they might not be able to swallow pills. And so there are situations where you want to use either a nasal spray or rizatriptan, which comes as a melt, and it's labeled all the way down to age 6. That's nice. It comforts families that it's labeled all the way down to age 6. So those are situations where you might use something else first. The other thing to think about is ideally the patient will take their acute therapy early on when the pain is still mild. There's this common misconception and thing that I hear a lot that triptans will only work if you take them early in an attack. That's not exactly true. It's really if you take them when the pain is still mild, they're more likely to help than if you take them when the pain has progressed to be moderate or severe. That's shown here with almotriptan in adults. This is the ACT-1 mild study. And you can see that if you treat when it's mild, 53.5% will get a response versus if you treat when it's moderate or severe, 37.5% will get a response. Still, in both situations, it's better than placebo. So it's still worth treating, even if the pain is moderate or severe at the time of treatment. And so a lot of times, actually, patients will wake up with the attack already in progress. They don't get that opportunity to treat when it's mild, and it's still worth taking their triptans. This is also true of the placebo. You can see that the placebo response rate is higher when it's mild too than when it's moderate or severe. And so this isn't just a quality of triptans. This is a quality of migraine. It's just easier to treat an attack when it's still mild than when it's progressed to moderate or severe. So you can generalize this, in my mind, to any kind of acute therapy that you're recommending. So taking that to its logical next step, not everybody gets aura, but about a third of patients with migraine have aura. This is a depiction of what visual aura might look like to a patient. So if we know that treating early, which tends to be when the pain is mild, should we back it up a step and treat when they're having visual aura, let's say? And this begs the question about what is aura. Aura comes from cortical spreading depression. So this is a slowly progressive electrical depolarization event, most commonly occurring in visual cortex, second most commonly occurring in sensory cortex. For a long time, we were inferring that from animal models. This recent paper from last year actually records it's an N of 1 study, but a really interesting one. A patient who also had epilepsy and so had an implanted grid. These electrical changes are small amplitude. This is not like epilepsy where you can record it easily on a scalp electrode when the patient has a seizure. So we haven't before been able to record the cortical spreading depression from scalp electrodes, but this patient had an implanted grid because they were preparing for epilepsy surgery, and the cortical spreading depression was actually able to be recorded for the first time in a human. But this overall is what's happening with aura. For whatever reason, and we'll talk a little bit about why that might be, treating at aura doesn't seem to be useful. So it doesn't seem to delay the headache phase, and it doesn't seem to make the headache phase less likely to happen. This is a trial where elatriptan was compared to placebo. There's two studies that have shown the same thing, sumatriptan and elatriptan. Both, when given during the aura phase, don't seem to be helpful. And so our guidelines say that it's safe to treat at the aura phase, but probably you could wait until headache starts and then treat right away at that point. And why is that the case? If you are, this one is open access, so I put a QR code because it'll link you if you just want to scan it. And the reason why treating at the aura phase probably doesn't make a difference is that it's way too far downstream in the attack. It's really migraine aura is more of a symptom of migraine rather than the initiating event. Sometimes people think that it's the initiating event of an attack, but it's more akin to the nausea, the photophobia. It's just one of the many symptoms. And this is another beautiful N of one study where some patient in Germany was willing to be scanned in an MRI scanner every single day for a month around 11 a.m. and to keep a prospective headache diary where they could keep track of their migraine attacks. And they had attacks that happened with aura and attacks that happened without aura. And what was found is what we know from other studies as well, that preceding the migraine attack by sometimes even 2 days, 48 hours, are changes in the hypothalamus. This is a part of the brain that's involved in regulating our mood, regulating our sleep-wake cycle, regulating our appetite. Changes in the hypothalamus happen much earlier than any of the other symptoms of a migraine attack. And this makes sense when you think about what the premonitory symptoms of a migraine attack often are. So before there is any headache, often patients will have premonitory symptoms. These might be things like photophobia or phonophobia, but they can also be food cravings, increased micturition, fatigue, irritability. Here are some examples of different premonitory phase symptoms, but they're things that naturally map back to the hypothalamus. And the way that I find it most helpful to ask if a patient can identify any premonitory phase symptoms, and sometimes initially they can't, but when you ask them about it and then you see them in follow-up, they're like, you asked me all those things, and now actually I realized I do sometimes experience that. But before a headache starts, before there's any pain at all, does your body ever send you a warning that one is coming? And it turns out that treating during the premonitory phase, which is far upstream of aura, does help with preventing a migraine attack. So this is a randomized placebo-controlled trial of abrogepant. We're going to talk more about gepant medicines and what they are in a moment, but treating during the premonitory phase symptoms does make it less likely that the headache phase will come. And so this is useful, whereas treating at aura is not necessarily useful. So back to our patient. She doesn't have any premonitory phase symptoms. Maybe she'll think about it, and next time we see her, maybe she'll think, oh, actually, I do notice these things, but at least at this time, that's not something we can really act on. So for her, it's going to make sense for her acute treatment to be that sumatriptan 50 milligrams with naproxen 500 milligrams as soon as possible at the onset of headache. And she's going to ask, how often can I use these? And this brings up this question about medication overuse headache. Is this something we need to worry about? Maybe, but probably not quite as much as it tends to get worried about. I want to give you an analogy, which is, let's imagine that this afternoon, a patient comes into our emergency department with their third episode of status epilepticus this month, and we treat them with a benzodiazepine and stop their status. And then we turn around and say, boy, you're having a lot of episodes of status epilepticus. I really think it's those benzos. You should stop taking those benzos. No one would do that, right? It's insane. But for some reason, we turn around and we're like, oh, I'm having a lot of migraine. I really think it's those migraine meds you're taking. With the patient with epilepsy, we would say, I think your epilepsy is really poorly controlled, and we need to adjust your anti-seizure medications. It's the same problem with migraine. Your migraine is really poorly controlled, and we need to adjust your preventive medications. But this is a thing that has gotten a lot of traction. I know you hear it from neurologists. I know it's not something that you're creating in your mind. and it's in the guidelines. People are going to worry about it. You got to limit the number of days per month that use the triptan and the NSAIDs and all these other sort of things. But it's really important to remember that all of the data on this are observational data. There's no randomized trial data on this question. And these observational data are inherently confounded by indication. If your headache frequency is going up, you use acute medicines more. If your headache frequency is going down, you use acute medications less. So it's a really tricky problem. I recommend this amazing piece. I think medication overuse headache does exist at some level, but I think it is greatly over worried about and is to a certain extent an entrenched idea in need of scrutiny. And even if we assume causality, so association is not causality, but even if we assume that the use of the acute medications are causally related to driving up the headache frequency, and even if we take the most likely culprit medications, benzodiazepines and barbiturates and opioids, you would have to undertreat between 3 and 5 patients to prevent one case of new chronic migraine from too frequent use of those medications. And those would be the most likely to be offender medications. Triptans, NSAIDs, acetaminophen, these are all less likely to be offender medications. But opioids and barbiturates, you still, if you assume causality, have to undertreat 3 to 5 patients. So give a little bit of a pause before you worry too much about this. I'm not saying throw it out the window. I'm just saying dial it down in how much we counsel patients about this. So back to our patient, she's got the sumatriptan with the naproxen, and she asks, how often can I take it? This is what I say. This is why it's in quotes. So you can use your triptan, ideally fewer than 10 days per month on average. But if you have a bad month where you need to take it more than that, it's fine. You should say that observational data is not just about frequent use, but it's about frequent use for at least 3 months in a row. So if somebody has a bad month, there's really no data that that's creating a problem. And the naproxen seems even less, we don't have time to go into all the naproxen data, but it seems even less likely to cause the problem. So from a medication overuse headache standpoint, it's fine to use naproxen more often. You might have a renal or a GI reason to limit it, but from a medication overuse standpoint, it's not a problem. And then naturally, someone might ask, what are the potential side effects? Sometimes when people take triptans, they'll feel a sense of warmth across their chest or a little bit of a tightness along their jaw or along their neck. It is not dangerous in our selected population who does not have a history of MI, and it tends to go away after the first couple of times that they take the medications. I like to warn them about it so that if it does happen, it doesn't frighten them. And it's really important, I think, to be honest about what the observational data show, which is about days per month of using the medications. A lot of times people will translate 10 days per month to 2 days per week. And what happens is, here we are on Thursday, the patient had a bad attack on Monday, they took their triptan. Here we are on Thursday, they're starting to have an attack, it's mild. And they're like, oh, I don't know if I should treat because maybe I'll get a worse one on Saturday and I can only take it twice a week. And then they don't act when it's mild. And 2 hours later, they're throwing up and it's all just missed. It makes them really anxious about when they can take their medicines. And so it undermines everything we just said about treating while attacks are still early. And there's no reason to do that. Maybe the reason they're having more attacks is that this is the week of their period and it's all going to equal out over the course of the month. And the data are about days per month. So there's no reason to switch that to be days per week. So this is what I actually write on a prescription that I'm putting into Apex for the sumatriptan. I'm saying, take 1 tablet by mouth as soon as possible at onset of the headache. It is safe to redose it 2 hours if you need to do that, maximum of 2 doses in the 24-hour period. I dispense 30. A lot of people will write 9, and I know that they're trying to avoid medication overuse headache, but that observational data is from days per month, not doses per month. And some people will need to take 2 doses during an attack. And so at the very least, give them 18 so that they could take 2 doses. But with copays being what they are, I think it's best to give them as many as they can get on a single copay. So I write for 30 and put in the refills. And then I write for the naproxen separately. All right, so she comes back a couple months later. She has tried that combination and it was not helpful. And she wants to know what else she can try. And in the interim, she has been started on sertraline for comorbid anxiety. And her pharmacist says, hey, you can't use a triptan when you're on an SSRI because you're going to get this problem called serotonin syndrome. And she wants to know if that's actually something to worry about. So this brings up two questions. If you don't respond to the first triptan, is it worth it to try a second one? And what's the deal between the triptans and SSRIs and SNRIs? And that first one first. So if the first triptan you try doesn't work, it is worth trying a second one. This is a trial of elatriptan in people who were previous non-responders to sumatriptan, and their 2-hour response rate, that's usually where we would look at the 2-hour time point, is just as good as a completely unselected population. So it does seem worthwhile to try a second triptan if the first one doesn't work. Whether that extends to the third, fourth, seventh triptan, I don't know. But at the very least, trying a second one is a reasonable thing to do. And from a practical standpoint, insurance will usually require that before moving on to something else anyway. So I think that's very reasonable and it's in the guidelines. Why might that be the case? Triptans really do have differences between them. They have different half-lives. They have different times to Cmax. And so they are subtly different. And so I think it does make sense that some people might respond better to one versus another, and it's worth that second trial. Moving on to the serotonin syndrome question. Depression and anxiety are comorbid with migraine. So this is something that's going to come up quite a bit. And if you had to restrict triptan usage among all the people who have comorbid depression and anxiety and are on one of these medications, that would have quite a bit of impact. Serotonin syndrome comes from overactivation at the serotonin 2A receptors. Triptans are quite specific for serotonin 1B, 1D receptors. Some of them also act on 1F receptors, but they really don't drive the 2A receptor. So from a pharmacologic standpoint, it doesn't quite make sense. In 2010, the American Headache Society sued the FDA under the Freedom of Information Act for the cases that led to this warning. There were something like 27 cases, and there's two different diagnostic criteria for serotonin syndrome, a more stringent one and a less stringent one. None of those 27 odd cases met the more stringent criteria, none of them, and only a couple of them met the less stringent criteria. So that warning is based on somewhat dodgy data. And this has been looked at in very large data sets of people who are co-prescribed an SSRI or an SNRI and a triptan. And the rate of serotonin syndrome was 0.6 per 10,000 person years, which is within the range of what you see from the SSRI alone. So it does not seem that there's any added risk of serotonin syndrome when you combine a triptan with an SSRI or an SNRI. So you don't need to avoid that. It's okay. But it is worth mentioning to your patient because a pharmacist will probably say something. So she didn't respond to the sumatriptan. And I have a whole way of thinking about which one you go to next. But for practical purposes, rizatriptan would be very reasonable in this situation. So we could do that either as a tablet or as a melt if she prefers, and combine that ideally with naproxen and reassure her it's completely fine that she is on an SSRI. And then she wants to know what happens next if that doesn't work. And from your standpoint, I think it would be, well, then I'll refer you to neurology because you have done more than your fair share. You've done second line triptan therapy, but you might want to know what we're going to do when she comes into neurology clinic, because then when she comes back and says, hey, now I'm on this medicine, it's nice to be informed about what that is. So most likely at this point, we'd be thinking about medications that act on CGRP, calcitonin gene-related peptide. This is a small peptide that is involved in a number of things in the body, has a vasodilatory function. It's involved in pregnancy and maintaining placental function. It's involved in the gastrointestinal system and helping things move on through. It's involved in bone healing. So it has a number of different roles in the body. But for people who have migraine, serum CGRP levels are higher than people who don't have migraine. And for people who have more frequent migraine, levels are higher than for people who have less frequent migraine. This is also true in children and adolescents. So on the left-hand column are people with migraine who are not in the midst of an attack, and that's their plasma CGRP level. Next one over is kids with migraine who are in the midst of an attack. And then the H group is with non-migraine headache. So imagine that maybe that's kids with tension type headache in the control group. So CGRP is an important, not the only biomarker here, but it's an important one. There are different ways to block CGRP signaling. So CGRP binds to two different receptors. It binds to what's called the canonical receptor or the CGRP receptor. It also binds to what's called the amylin 1 receptor. And the A column here is the natural state. So the CGRP is little green triangles. And in the natural state, it's binding to the CGRP receptor and signaling, or it could be binding to the amylin 1 receptor and signaling. What you could do to block it is shown in B. You could make an antibody that soaks up the CGRP itself. That's one possible strategy. Or in column C, you could make an antibody that blocks the receptor, the canonical receptor. If you do that, the CGRP still exists in the bloodstream, and it could still go on to bind with what's called here the other receptor, but is the amylin 1 receptor. Another way to block CGRP signaling is the gepants, which are small molecules that block the canonical CGRP receptor. There are 4 of these that are out in the market, 3 for acute, 2 for preventive. And the acute ones are abrogepant, zavegepant, which is available as a nasal spray, and rimegepant, which is dissolvable, so you don't have to be able to swallow pills. And then for prevention, there's atogepant. And again, rimegepant showing up here because rimegepant has been studied both as an acute therapy and as a preventive therapy if used on a regular basis. So here's just a little table to give you a sense that there are 4 different monoclonal antibodies for blocking CGRP or its receptor. 3 of them block CGRP itself. The first one that came out on the market was arenimab that blocks the receptor. They have relatively long half-lives on the order of about a month because they're not broken down by the liver or the kidneys. They're broken down in the reticuloendothelial system, the cells lining the blood vessels, just like all of our other IgGs are broken down. So it does have a long half-life. And when I first started prescribing these, I was curious about how much IgG am I giving to my patients? Is this like giving IVIG or is this something different? And 1 mg per kg of IgG is equivalent to 0.1% of the body's total IgG. So if we took arenimab, just for an easy number, if we use this 70 milligram dose, let's say we have a 70 kilo patient, we use the 70 milligram dose, we're giving them 0.1% of their body's total IgG. So even if you're giving more, you're giving 0.2, 0.3% of the body's total IgG. So this is not like giving IVIG. Oh, and the important part here in yellow is that since August, fremanezumab has been FDA labeled for migraine prevention down to age 6 based on placebo-controlled trial data, which we'll talk more about in a moment, but that would be an on-label use. Here's the trial. So this trial was first reported in September of 2024 at a conference. It's a phase 3 study. Kids down to age 6 who were randomized to either the fremanezumab or the placebo and then treated for 12 weeks. Dose for those who are over 45 kilos is the same as the adult dose, which is 225. Smaller kids got 120 milligrams. Here is the main finding, essentially, that you see separation from placebo as early as week 4 and moving forward. And also the 50% responder rate. That's a very common outcome in migraine prevention trials where it means what proportion of patients had at least a 50% decrease in their headache frequency. So let's say at baseline you had 10 headache days per month. Now you have at least 5 instead of 10 or fewer. That would be a 50% responder person. And they're using fewer days of acute medication. So positive trial of fremonezumab in 6 to 17-year-olds. And this actually, even though the FDA label came out in August, this is just published in the New England Journal of Medicine in the last 24 hours. So you're very up to date and you can go and read it. It's exciting that it just came out formally quite recently. Okay, so we're back to that patient who you're probably at this point sending over to neurology because she hasn't responded to 2 triptans and you've done more than your part. And in all likelihood, we would be trying to give this patient a gepant for her acute treatment. We have been using gepants off-label since they came out. We've recently published our use of them preventively, and we're preparing to publish our real-world evidence of their use acutely. But for this sort of situation, it would probably be either a brogepant, which is available as a tablet, or, that says rizatriptan, but it should really say romagepant, the melts. So certainly you're going to see a lot more about CGRP therapy over the next couple of years. Christina Spurka, who she directs the Pediatric Headache Program at CHOP. She and I basically recently combed through clinicaltrials.gov to find all of the upcoming trials in kids and adolescents about CGRP therapies and other therapies. And this one is also available open access, so you can scan the QR code to look at it. But here are the preventive trials. There's quite a few that will be reported even this year. So within the next 12 months, we're going to be seeing quite a bit more data coming out on the use of the CGRP monoclonal antibodies for prevention in kids and adolescents. And on the acute side, this year, we'll see results from the brogepant trial. Romagepant will take a little bit longer. Zavegepant, which is the nasal spray, that's the most recently one to come to the market, and that's still a little bit earlier in the process. But within the next year or a couple of years, you're going to see quite a bit more on this story. Okay, so we're done with that first patient. Let's just talk about the second patient, who will be a faster case. So this is a 14-year-old boy with migraine. He's having a higher attack frequency at 2 days per week. The family wants to know what can be done to bring down his migraine frequency, but they favor a non-pharmacologic approach. And he's an 8th grader. He's got a choice with which high school he wants to go to, whether he's got one that starts at 8 a.m. and he's got one that starts at 8:30. They want to know, does this matter for his migraine management? Should they be thinking about that when they're factoring their decision? And this introduces the whole concept of preventive therapy, what we do to lower the frequency of migraine in kids. This is a complex, multifaceted, multidisciplinary sort of topic, and the medications are just one piece of it. Using acute treatment rationally is definitely part of it. If you have a 2-day long attack at baseline, but we get you an effective acute therapy that stops it within just a couple of hours.
All clear. Fire tested.
Good news. If you have effective acute therapy that stops it within a couple of hours, we've decreased your headache days per month through rational use of acute therapy. For kids who have chronic migraine, that's at least 15 days per month for at least the last 3 months. If we combine pharmacologic therapy with cognitive behavioral therapy, that's better than giving you just the pharmacologic therapy. But there's also this piece that is often referred to as lifestyle management or healthy habits. This refers to things like regular sleep, regular meals, good hydration, regular exercise, all things that sound very healthy. But sometimes it, I think, is presented as if it's a free choice on behalf of the patient and the family. But we all know that that's not really how things work, and people have different options based on a number of factors that may or may not be within their control. And so it makes me think differently about, where does the responsibility really rest for lowering migraine frequency in young people? What proportion rests with us as clinicians? Certainly our prescribing of medications and neuromodulation devices is going to be resting with us, but that's not the whole picture. How much rests with the family and the patient and what they are choosing with lifestyle choices? And how much actually rests at the society level? Things that are not necessarily free choices for families. And while guidelines recommend that we counsel people about things that might influence headache frequency and educate them about modifying them, not all of these habits are potentially modifiable. So just taking sleep is what I think is an interesting example. Adolescents have a physiologically delayed sleep phase. They usually can't fall asleep before 11 p.m. Smartphones probably make that worse, but this is independent of smartphones. They have a physiologic, normal delay in sleep phase, and they need at least 8 hours, often more, of sleep per night. So, from a physiologic standpoint, they ideally are not waking up before 8 a.m. So, the American Academy of Pediatrics recommends that all middle schools and high schools begin no earlier than 8:30 a.m. to reflect the physiology of adolescents. However, the majority of middle schools and high schools begin earlier than 8:30 a.m. for a number of reasons that have nothing to do with adolescent physiology. And so that means that we are shifting kids from their physiologic wake time to a required wake time and often truncating their total night of sleep. So we wanted to look at, does this make a difference for kids with migraine? And our hypothesis was that those kids who attend a high school that follows AAP guidelines and starts at 8:30 or later will have fewer headache days than those whose schools start earlier, was sort of the underlying question of, could this help as much as starting a preventive medication helps? And just to give you a little bit of context, in a randomized placebo-controlled trial, whether it's in the kids or adults, usually the mean difference in headache days between the active arm and the placebo arm is about 1.5 days per month. So that's sort of the effect size that you see typically in trials. So we've recruited high school students in the US using social media advertisements, screened them for migraine using criteria that mimic ICHD-3, invited them to complete this online survey. This is right before the pandemic started. We were trying to get the sample in a quick period of time so we didn't get effects from vacations, and asked them a number of questions about their school schedule, how they commute, their breakfast, all sorts of things. And indeed, this is about 1,000 high schoolers with migraine, and those who attended the early start schools, so this is schools that start earlier than 8:30 a.m., did have more self-reported headache days than those who went to a late start school, almost 8 days versus almost 5 days. Certainly the mean time that their school was starting was earlier, 7:56 a.m., and those at an early start group, but this is how we divided the groups. And the proportion who are getting at least 8 hours of sleep was higher in those who went to a late start group. So the unadjusted mean difference was almost 3 days of headache per month. But then we adjusted. We said, what about total hours of sleep, sleep variability? This is how much it varies, whether it's a weekday or a weekend day, how much homework you have, how often you're skipping breakfast, if you're on a preventive, all these different factors. And it's still held up to adjustment for all of those things with a mean difference of 1.3 headache days per month, which is just about on par with the mean difference that you see between an active arm and a placebo arm in a pharmacologic migraine preventive trial. This is obviously based on self-report, it's retrospective data, but if borne out in prospectively collected data with sleep diaries and headache diaries and ideally actigraphy, this could be a societal level shift that would result in nationally thousands of fewer migraine days per month among adolescents. And this is not necessarily something that a family can change. They can advocate with their local school board, but they can't actually change the high school start time. So if we're counseling this patient and they do have a choice, go to the one that follows AAP and starts at 8:30 or later. But not everybody gets that choice. But if we do have a situation where we can, then fantastic. So to summarize, when we're taking a headache history, we want to aim to make a specific headache diagnosis, not just dividing primary from secondary, but then a specific primary headache diagnosis. Migraine is very common in children and adolescents. First-line acute therapy, if they're not responding to something like ibuprofen, is going to be combining the triptan with the NSAID. CGRP therapies can be used for acute treatment. They can be used for preventive treatment, or they could be used for both. And there's quite a bit that's going to be coming in the next year or so. You can read the New England Journal trial that just came up in the last 24 hours. And that responsibility for preventive therapy may rest in different proportions with different parties, not just with the family and the patient. Thank you so much for your attention and interest, and I'd be happy to take questions. Sandrine.
I learned a lot. Thank you so much for this great presentation. I actually have a question about that sleep schedule data, because I have to admit I didn't look at this for a long time, but I looked at it at some point, and my understanding was actually that the shift in the rhythm for adolescents is a shift from their pre-puberty time, and it becomes 11 o'clock in the Western world because we don't send our kids to bed at 7 o'clock when they're 8 years old. But like it wouldn't necessarily be the only solution.
Yep.
And I'm thinking about, parents with jobs and with younger children, and there could also probably be, it might need to be studied, but what happens if you actually tell your younger children bedtime is at 8, and then you get into puberty and you sit 10 o'clock, and then change the whole world around us.
Maybe should I repeat that for people who might be online? So the question and comment was about how that physiologic delay in sleep phase in adolescence may not really be 11 p.m., but may be culture specific. And if we had kids pubertally go to bed earlier, then the delay might not necessarily need to be 11 p.m. I think that'd be really interesting to look at. I haven't seen anyone look at that. The other thing that made me think about is a lot of times there's some data about melatonin for migraine prevention, and we use that in our program. And sometimes people are asking, if that's a problem, which should also be studied, long-term exposure to melatonin in adolescents. But we're all doing it all the time, right? Especially at this time of year. We evolved to have darkness from sunset to sunrise. And right now that's maybe 5 or 5:30 till, I don't know, 6:30 or 7 in the morning, but we keep the lights on until about 10 p.m. So we're all already modifying our body's melatonin production every single night. So just by choosing to use electrical lighting after sunset, we are messing with that system, and that could be rethought too, potentially, at a societal level.
Then there's a question from the Zoom. Brandon asked, do other types of migraine without headache, like vestibular migraine, also occur in children? And if so, how do you approach those with medications?
Yeah. Okay. So the question is about vestibular migraine and whether it happens in children, and it does. Vestibular migraine to me, it's a little bit of a funny label because you still do have to have headache attacks to get diagnosed with vestibular migraine. It's not like you can never have headache with any of the attacks. It's just some of the attacks might be characterized predominantly by vertigo, and other attacks might have headache and vertigo. And that situation definitely happens in kids, and it gets called vestibular migraine. To me, it's kind of like saying, whatever the most bothersome symptom is, we're going to call it that kind of migraine. It's like photophobia migraine or nausea migraine or phonophobia migraine. I understand the rationale for it in ICHD, and that's that a lot of these patients will initially present to an ENT clinic and because of the complaint of vertigo, and it's to help the ENT community think of migraine on their differential. And so that's why vestibular migraine is treated a little bit differently with a special label, whereas there's no such thing as photophobia migraine and phonophobia migraine. But to me, it's just, what is the most bothersome symptom? Is it this, that, or the other? These are all exceedingly common symptoms. At any rate, I think it does happen in kids. We definitely see it in our program. And we treat it the same way as we treat migraine generally. There is a nice study in adults by Jeff Sharon, who's an ENT here at UCSF, of galcanezumab, one of the CGRP monoclonal antibodies being used for preventive therapy for adults with vestibular migraine. It was a positive trial. So certainly I think that supports the overall principle of treating it as migraine in general, but it does happen in kids too. Hello.
Great presentation. Thank you so much. I had a question about abdominal migraine, and do you feel like it also fits into that, right? Like it's just A,
Yeah.
And then B, it was on your list of premonition symptoms, abdominal pain. So do you feel like that's
Ooh,
just
that's
part of abdominal migraine, or is it actually just like a premonition symptom? It was pretty low frequency as a premonition.
Yeah. That's interesting. Okay, so the question is about abdominal migraine and treatment, and then abdominal migraine and overlap with premonitory symptoms. And for the first question, I do think of abdominal migraine as just an earlier life manifestation of migraine that a lot of times we'll meet them when they're 6 or 7 years old, and the attacks are abdominal pain and nausea, vomiting. And then when they're 10 years old, it's abdominal pain and headache and nausea, vomiting. And when they're 13 years old, it's headache and nausea, vomiting, and the abdominal pain component has receded. I think it's just a little bit of a difference in how the brain is perceiving symptoms at different developmental stages. And yes, I do treat it the same way. Abdominal pain as a premonitory symptom is an interesting, I have to go back and look at that slide at how often it was listed there. It's not one I hear as often clinically. I would think that it could certainly be a premonitory symptom, but it might, I wonder if it's also catching some of those kids who are in that transition from mostly manifesting with the abdominal pain component to mostly manifesting with the headache component. And it might come down to how you ask. A lot of things in headache come down to how you ask. But that's an interesting question.
I have two questions. The first is, do you think there's any role for riboflavin? And then the second is, what do you tell the person who says, I'm pretty confident these are migraines, but I'm not confident in my fundoscopic exam?
Yeah. Okay. So first question was about riboflavin, which is vitamin B2, but I always recommend that patients remember the word riboflavin because there's a million different kind of B vitamins, and I've had patients buy the wrong thing. And I do think that there's definitely there's an adult positive RCT for riboflavin 400 milligrams daily. And then there's some pediatric data, which is more muddled, but smaller studies, higher placebo response rates, showed efficacy in the subset with tension type headache, but not migraine. But were those tension type headache kids really kids with subtler migraine? I don't know. I use riboflavin all the time. I think it's fantastic and very well tolerated. It's just a muddier situation for the pediatric data. I'm sorry, I just blanked on the second question. Fundoscopic exam. Yeah. So no shame. It's hard, right? And one of the things that we got in our pediatric neurology clinic, which has been amazing, is every single room is equipped with a panoptic ophthalmoscope, which really is a game changer and makes it so much easier to see. I mean, I have one in my purse right there. I carry it with me literally everywhere I go, but it really does help a lot. But if for some reason you can't see it sometimes it's hard for everybody. It's hard. You ask them to go see ophthalmology or go see optometry and get a dilated exam where someone can put eye drops in and actually take a really good look, because sometimes it's tricky. And so getting a second pair of eyes on the eyes, I think, is the right thing to do. And if everything else in the history is consistent with migraine, everything else in the exam is normal, I don't think that's an emergency situation. I think that's a nice cross your T's, dot your I's, and we should do it. But I don't think you have to do it that day. And so if you need to send them to somebody else to look, no shame in that. Yeah.
Ms. Scott,
Thanks,
I have
Phil.
a question regarding you talked about a lot of studies that were positive studies and seem to give a lot of credence to that. But as you know, much better than me, there was a very big negative study.
The CHAMP trial.
8 years ago or 7 years ago that was sort of dismissed and didn't change practice habits. And I wonder
Yeah. So
positive and negative studies and how they influence your practice.
So I think the question is about that there have been a number of preventive studies in kids that have not had separation between the active arm and the placebo. Most notably, I think the CHAMP study, which was also published in the New England Journal in 2017, amitriptyline versus topiramate versus placebo for migraine prevention. And no matter which arm you were in, 70% did great. They got a 50% responder rate. And this is often translated into kids having a higher placebo response rate than adults, which I think is confounded by age. So whenever you've got a pediatric migraine prevention study, they've had migraine for like maybe 6 months, maybe a year. And we're enrolling them in a study and we're saying this already works for adults. We know that. We're just now looking at whether it also helps in kids versus adult migraine preventive studies. the mean age is 40. They've had migraine for 20 years, and it's never been studied before in humans. And so the difference in response rates, I think, is not necessarily a difference in placebo response between kids and adults, but I think it's confounded by duration of migraine disease and confounded by what we say to them about what we already know about its efficacy. So it didn't separate from placebo, but I think that there wasn't an arm where you did nothing. And there were a lot of potentially active co-interventions in that study. So we gave them NSAIDs and triptans. We gave them rational, appropriately dosed acute therapy, which, if it's effective, like I was saying, if you have a 2-day attack and now it's becoming a 2-hour attack, that's going to bring down your frequency. They were given all kinds of advice at monthly intervals for 9 months or so, because that was a pretty long study. And so there were other active things that we were doing that I think could potentially be helpful. And people got better. Like it wasn't as if nobody was getting better. The problem was that everybody was getting better. And so I don't know that. I think part of the reason it didn't change practice is that there wasn't an arm where we did nothing. I think it just reinforced making sure we've got good acute therapy. We're talking about all the elements of preventive therapy. I, even before that study, was already using things like riboflavin as my first line preventive therapy, because I think if you've got a preventive that has a side effect profile similar to placebo, which is not to say no side effects, just similar to placebo. Placebo has side effects if you read the tables. Then you can potentially get the same benefits without introducing some of the greater adverse events that are seen in the other medications.
We are at time.
Great.
One question on the Zoom that maybe can be real quick, and that is our post-concussion headaches migraine.
Yeah, it's a good question. It's not a quick question. I think sometimes is the answer. I think it depends on what their pre-existing headache history is. Sometimes a kid who has a clear pre-existing history of migraine gets whacked on the head and has an attack that looks a lot like their usual history of migraine, just a little stronger and a little longer. Maybe that's a provoked migraine attack, versus a kid who has no history at all and now has this problem. That's probably a little bit of a potentially different situation. So I think that's hard to answer in a quick one. Thanks so much. I'm happy to stick around.